Okay, so chapter 42 is bowel elimination and gastrointestinal disorders. One of them that we spoke about was cleft lip slash palate. Um, they're both separate anomalies or disorders, but they're very closely related as they both have to do with these sort of abnormal openings, but one is in the lip and the other one is in the soft or hard palate. And this typically develops while they're in utero. So, how do we diagnose this? Well, at birth or at an OB sonogram around 20 weeks gestation, we can determine if they have either cleft lip or cleft palate. And we also would know if when the baby's born, if they have cleft palate, especially if they start having formula that comes out of their nose. That indicates that there's an opening in the palate. Um, so how do we manage this? Well, it really just depends on the severity of the defect and how the team approaches it. But always we have to think about if there's some sort of like right opening in the lip or there's some sort of opening in the palate, we have to worry about aspiration, right? So the best way that we can help prevent aspiration is making sure that we modify feeding techniques. That's going to be your priority because that allows for adequate growth and it prevents aspiration. So you need to make sure that you properly teach them how to use feeding techniques. Um, and the proper use of like these, like there's like these bottles that have these like special nipples on them so that they can sort of mimic um the breast. Those actually help decrease the energy that it would take in normal breastfeeding to promote adequate nutrition. So, we do something called ESSR to modify feeding. So that's um, an enlarged nipple, right? Um, which is going to, you need to simulate the suck and then they're going to swallow it and then they're going to rest. It's kind of how that little, like those nipple bottles work. So it's really enlarged, right? So it stimulates their sucking reflex, they swallow it, and then they take a break. They may need more frequent and smaller feedings to decrease fatigue, and they must be fed at a 45-degree angle. Okay, whether it's cleft lip or cup palate, doesn't matter. They need to be put at a 45-degree angle to prevent aspiration. And the cleft repair will usually happen around 3 months of age. The cleft lip repair, sorry, will be 3 months of age, but the cleft palate repair will be around 9 months of age. And because that's a palate, like the hard palate or the soft palate amount, depending, that requires multiple procedures. So there's a few different things we need to be concerned about, right? One of them is aspiration, but the other one is adequate fluid balance, right? So for especially we're talking about little babies, we need to make sure that a baby has a minimum of 6 wet diapers in 24 hours. 6 wet diapers that you know they have a good fluid balance. Other things is hydration status. So looking at the fontanelle, right? The ability, if they're able to cry and if their mucous membranes are moist. Also tracking their weight, right? And we talked about the different weight, how much a baby should weigh over, the span of such and such times. Um, Feeding difficulties, right? Because of the fact that they have this defect. Acute ottious media, and that's because we were talking about, right, when they have an ear infection, one cause of it could be from um, not properly being fed or having problems with the latching on. So the fluid and could start building up in those occasion tubes. So we have to worry about that. They could have altered dentition, delayed or altered speech development. There's also cosmetic concerns, such as if they have the surgery, especially if it's like on the lip, will it cause scarring, right? And parental reactions and making sure that we still encourage bonding. Now, regardless of the procedure, um, preoperatively, we need to look at their nutrition, right? Make sure they have adequate weight gain, prevent aspiration, always assess respirations prior to feedings, and we want a CBC, especially for platelets, because we want to make sure their platelets are good so they're not at risk for bleeding. Post-operatively, our priority assessment is respiratory status. Then, after we do respiratory, we position them on their side or their back. And that's because positioning on their side of their back also is going to help make sure that if there is any like, sort of like bleeding or buildup, they're not going to choke on that, right? Um, Okay, so we also want to look at Rita because we want to look at for redness, arrhythmia, edema, discharge, and approximation, right? In terms of how the site's healing, but also making sure we're looking for infection. They're gonna have something called a Logan bar, which is gonna be a metal bar that holds the sutures together. Um, and if especially for those cleft lip babies, we'll do something called arm and elbow restraints. That's a priority intervention, right? So our priority assessment is respiratory status. Our priority intervention is going to be arm and elbow restraints, and then also positioning them on their side or their back. And that's also because when we use the arm and elbow restraints, it's almost like tying them down in a way, so they can't move or touch that or the surgical area. So that's gonna make it, hard to do a lot of things, and the baby can't really move their hands. So keeps them really stiff. So that's why we want to keep them on their side or their back, especially because like we want to prevent complications. Now, we don't want to put anything in their mouth until cleared, right? So we want to make sure that they're cleared by the doctors before we start putting things in their mouth because they're at risk for aspiration. So they should have no oral suctioning, no spoons or pacifiers. And if they're gonna have, anything, it has to be at a 45-degree angle, right? Um, okay. A next thing is that we have acute GI disorders resulting in dehydration. So infants and young children are specifically vulnerable to fluid and electrolyte imbalances, and they have a higher percentage of body weight of being mostly of water. So because of that, right, since the child has more body water, right, when they have problems when it comes to eating, they lose that a lot more quickly. They also have a higher basal metabolic rate in infants, so there's a higher rate of water turnover, which, as I was mentioning, will make dehydration occur very rapidly. They also have immature kidney function. We're talking about an infant, so a baby doesn't have the kidney function the same way as our adult selves do. So we need to consider that. Um, so that means they're going to have less concentrated urine and less of a urine output. So we need to really watch out for that. Especially got to watch out for those. We need to have 6 wet diapers in 24 hours. Infants have a higher rate of peristalsis than older children, so they kind of take things down really quickly and they poop things out really quickly. That's why, you know, we have those 6 wet diapers or more. Um, there's also different ways that they could lose fluids, right? We know that if your respiratory rate increases, your water loss increases, but also babies have a higher respiratory rate, which puts them at an even greater risk for dehydration. So, for an infant, when we're thinking about manifestations, we're thinking about dry mucous membranes. So the lips could be dry and cracked. Um, they have a decreased urine output, so that'll be less than 1 milliliter per kg per hour. Please know that. Know that they're going to have an increased urine specific gravity. Why? Because they're having less urine and whatever's coming out is going to be more concentrated, have more stuff in it. So it's going to have a higher urine specific gravity, so greater than 1.020. Infants, especially if they're younger than 18 months, they could have a depressed interior fontanelle. That's why we want to assess the fontanelles. They could look gray, molted, pale. They could have reduced skin turgor. They could have a delayed capillary refill, which is going to be greater than 2 seconds. They could have absence of tears, and they're going to be hypotensive and tachycardic. Remember, the tachycardia is a compensatory mechanism to the hypotension. So, how do we evaluate? Well, weight, like we say in med surg, is always going to be the best indicator of hydration status. So, we are always doing daily weights. Other things that we could look at is CBCs. So, we know that they're going to have an increased hematocrit level. And we want to look at serum electrolyte levels. Um, because those have a risk of being elevated as well. We want to look at urine output for the color and the specific gravity, which we said would be greater than 1.020 would be indicative of dehydration. So there's different types of dehydration. So there's minimal dehydration, which would basically be age appropriate, where we could just give them the fluid replacement based on their age. So if they're like a baby, we could just kind of feed them, right? Not really so severe. You don't have to do anything other than just kind of replenish them orally, right? But if we're talking about mild to moderate dehydration, we actually want to do oral rehydration, do Pedialyte, and we want to resume age-appropriate diet when the dehydration is corrected. So we know for minimal, we're thinking about age-appropriate diet with fluid replacement, right? So just whatever is appropriate. Then if we're talking about, teenager, they can drink it. If we're talking about like a little kid, like preschooler, they can drink something, right? But if we're talking about mild to moderate dehydration, we first want to do oral rehydration with Pedialyte, and then once that dehydration gets fixed, we could do resuming, normal age appropriate drinking and dietary activities. If it's really severe, like really, really severe, we're going to give them a bolus of parenteral fluids. So we're going to do isotonic solutions, and we're going to keep them NPO, and we're going to give them IV fluids. And then we're gonna, once that starts to get better and the dehydration labs become more stable and alert, they'll do the oral rehydration therapy with the Pedialyte and things like that. And then once that's corrected, they're alert, they're stable, they're getting that, they're doing fine with that, we can resume age-appropriate diet. So just think about, right, age-appropriate for the littlest type of dehydration. As it progresses more, the interventions become more, right? So, we're talking about Pedialyte or Infolite or Rhisolite, any of those. Or rehydration solutions can also include tap water, milk, undiluted fruit juice, soup, or broth. Would not be appropriate for like oral rehydration in terms of a rehydration solution, but that could be, something to consider for like an older child or when it's actually more appropriate. But if we're talking about an actual oral rehydration solution, it needs to be something like Pedialyte, Infolite, Rhisolite, and that's because it has electrolytes in it. Tap water, milk, undiluted fruit juice, soup broth, they do not have the electrolytes that are going to help, especially in these really severe cases or the more moderate cases. And we always want to make sure we do reevaluation after we give oral rehydration, so we know if it needs to be continued. Do we need to do more informations? And once they're rehydrated, we can resume a regular diet. Nursing assessments. Once again, we talked about the different manifestations, so we want to be mindful of the manifestations of dehydration. Look at the hydration status of their mucous membranes, the fontanelles, if it's appropriate for their age, right? INOs, daily weights, right? The best indicator. Monitor lab values and electrolytes, right? We don't want to give them fruit juices or carbonated beverages because they're high in carb content and they're low in electrolyte content. Caffeine, no, because it's a diuretic and that's going to make their hypovolemia worse. Avoid chicken or beef broth because there's just too much sodium. That's also not good. And we want to avoid the brat diet, which is the bananas, rice, apples, and toast diet because it's low in energy, protein, and fat. I would know this part especially. Um, so when it comes to, I don't know if she's gonna ask you how to do the math, but there's a thing where you can determine the fluid need, so it really just depends on the weight. So, if they're between 0 to 10 kilograms, you're gonna basically do 100 milliliters per kg per day. So that's how you would add it up, right? So if it's, 1 kilogram, um, it would be, 100 milliliters per 1 kg per day, right? If it's two, it'd be 200, things like that, right? If it's 10 to 20, it's going to be 1,000 milliliters plus 50 milliliters for each kg above 10.
I'm
So,
sorry, Lisa.
hmm?
I'm sorry. Is there any way you could send me this so I could go through this as you're going through it?
Yeah, sure. Just give me 1 second.
No problem. Thank you.
So, basically, so let's just say they're 12 kg. So it's gonna be, 1,000 ml plus 50 ml. So you're gonna kind of just add 50 for every kg above. So if they're 12, they're 2 kg above, which would be basically um like adding 50 twice. I think I'm doing that right. I'm not 100% sure. Um, but for 20 to 70 kg, it's 500 milliliters plus 20 ml for each kg above 20. So you just kind of have to figure out how much they weigh and then add whatever is appropriate. So in this case, it's 50 for every kg above 10, between the 10 to 20 range. And if it's 20, it's going to be 20 ml for every kg above 20.
Wait, Alicia, I don't. For some reason, that particular spot confuses me. So you see how we have an example at the bottom that says calculate the ml per day and hourly flow rate for a child that weighs 14 kg. So 14 is between 10 and 20. So are we going to multiply 14 by something? Or it's just like the 1,000 plus the 50 and then what?
So I think I'm doing this right, but I don't want to assume. But
Mhm.
if it's 14 kg, we're gonna look at the second one, which is 1,000 ml plus 50 ml per each kg above 100. So since it's 4, it would be basically 50 times 4 plus 1,000, which I think would be 1,200.
So you only use the extras that come after it. So you see how we have the 10 to 20 and it's 14. So it's gonna be 4 times 50 plus 1,000.
Yeah, I'm pretty sure it's like that. I think so. I haven't done this in a while, but I think that's how it is. But I do know it has to do with only whatever goes above that range. So if we were talking about 22, the same sort of principle would apply where you're just gonna do like 20 times 2 and then add that to the 1,500. That's how I think it is.
Oh, so the 1,000 and the 1,005 is not being multiplied by anything, but it's the ones that come after it.
Yeah, it's like the 50 or the 20. For the first one, if they're between 0 and
Oh.
10, it would be 100 ml per kg per day. So it would be, if they're 0, they can have 0 ml, but then nobody's going to weigh
So
0.
if
But
it's 9,
1,
it's gonna be 900.
that's what I think. Yeah, which makes sense, right? Because if you think about it, if this is 900 for kg, right? Once we hit 10, it becomes 1,000 plus 50 per every kg, right? And then when they're
Mm.
20, they're I guess it's 1,500, but it kind of makes sense mathematically.
Hmm. Yeah, because I was thinking that's why I was confused because I was thinking you multiply the if it's 14, you multiply the 4 by both the 1,000 and the 50, but you only multiply with the 50 or the 20 if it's above 20 or 10. Okay.
I'm Yeah, I'm pretty sure that how it is. I don't want you to take 100% my word, but I feel like that makes sense. And you could probably like look it up to see if my math made sense and if it doesn't, because I think you guys might have done a problem like that in class. I'm not sure if she did it with you. Um, but does that make sense what I'm saying?
Yeah, she did, but I was confused. But now that you spoke on it, that we multiply the like the extras with the numbers that come after like the 1,000 or the 1,005, that's what we multiply to add to the 1,000 or 1,005 to get the right answer. Okay, thank
And
you.
I double checked because I don't want to tell you that and I'm wrong. The
No,
answer is
because
1,200.
yeah, when we did it in class, the answer was 1,200. So that means that what you're saying is actually right because 50 by 4 is 200. And when you add it to the 1,000, it's 1,002.
Yeah. Okay, I'm happy because I was getting a little nervous that maybe I'm confusing myself and I was reading it wrong. But yeah, that's how you basically do it. But you would have to know this like formula thing to know how to do it. You see what I mean? Like you just have to know that if they're between 10 and 20, I have to do 1,000 plus 50 and then 50 times whatever kg that goes above 10, So it's something that you'd have to memorize. I don't know if she'd give it to you,
She
but
said we shouldn't memorize it, that she's gonna provide it. So
oh, well then don't memorize it. Just know how to do it. As long as you know how to
yeah.
do it, then that makes it 100 100 times easier.
I have a question, Alicia. I'm sorry. What happens when it's either a 10 or a 20? Which one do you use?
Oh, um, I guess because it says 0 to 10, I would do
Yeah.
this one. And then
Okay.
this is 20, right? Because it says above 20. So I would say
Okay.
20, you're still using this one.
Okay.
That's what
Okay.
I would do. And if I got that wrong, I would just say that that made the most sense. Being I'm looking at this weight range and I'm looking at the
Right.
corresponding thing.
It's
That's what
above
I would do.
it, but if it's 10 and below, you would do the first one.
Yeah, so 10 ends here, right? Which makes sense because then you're not doing it for 10, it's for above 10.
Right.
So
Above 10.
11,
Oh,
21. Yeah.
right. Okay. Perfect. Thank you.
But I don't think I would hope she would not do 20. I would think
Right.
she'd give you
But
21.
just in case. Thank you, though.
Okay. There's a chart in the textbook that compares the dehydration just to kind of get an idea of what happens between like mild, moderate, and severe. It could be good to just read it over so you could just see. Um, but like with the different body systems, like what can you expect for like the heart rate, blood pressure, things like that. Um, but okay. So the next thing is a vomiting acute GI disorder, which is going to result in dehydration. So we have to be very, very careful with this, right? Now, here's the thing with vomiting, there's a lot of different disorders that cause vomiting. So we need to know what kind of vomiting, how does it present itself, right? Are they projectile vomiting? The way it looks, if do they have a fever? Is it infection that's causing the vomiting? Is it accompanied or not accompanied by diarrhea? And are they having manifestations of dehydration? Now, for treatment, we need to prevent dehydration. So we want to make sure they're constantly having fluids, right? Um, and we talked about it depends on the type of dehydration that determines how we're going to give them fluid. And we talked about that, right? Minimal, just regular, whatever they do drink, right? If it's moderate, we're talking more about like oral rehydration therapy like Pedialyte, and then really bad, we're talking more like IV fluids. But we also want to put the stomach on rest, meaning NPO. Don't feed them. Don't put anything in their mouth for a few hours, especially when they're vomiting. Okay, we just want to leave the stomach alone. Okay. Now, gastroenteritis is an acute GI disorder that results in dehydration. That is a dehydration disorder that causes diarrhea, whereas vomiting can also cause, dehydration, but through vomiting, right? That's a different type of way to lose fluid. And this is another way. So, this can be caused by a virus. I would know what can cause it like a rotavirus, norovirus. If it's bacteria, it could be Shigella, Salmonella, E. coli. Okay, I wouldn't emphasize on parasite, but I would know that it can be caused by parasites, but maybe I don't think you need to know which one. For manifestations, right? Diarrhea doesn't change, right? But we're looking at watery diarrhea, so watery fluids, right? A lot of abdominal cramping, foul smelling, could be bloody. It could be mucousy, greasy, or watery. They could have fever or chills. May be present if they're vomiting. Look for signs of dehydration, right? So a fever could be present, but it's not, they have to have it, they could have it, okay? So for rotavirus, it's the most common cause of diarrhea. I want you to know this one. In unvaccinated children under 5 years of age, they're going to have a fever greater than 101 degrees Fahrenheit. They're going to have foul smelling, watery stools that will last for 5 to 7 days. It's transmitted through the fecal oral route. So, kids don't wash their hands, or somebody does a diaper change, doesn't wash their hands properly. There you go. Um, Now, the rotavirus vaccine can be given at 2, 4, and 6 months of age. I think it's given at all of them, like 2, 4, 6 months of age, each of those times. Okay. The next thing is it's based on presentation, right? So if they have a fever and that's foul smelling, we know it's rotavirus. If they don't have the fever, it could be something else, right? That's how you have to kind of think about these things, especially when it comes to disorders, like what symptom or set of symptoms separates one from the other. So in this case, with rotavirus being the most common, we're looking for a fever in addition to that, right? And unvaccinated children under 5. Lab tests, we want to do stool and cultures because they could have blood in the stool, right? Because we said gastroenteritis. Um, Hematocrit, electrolytes, especially because we're looking for potentially dehydration. Urinalysis, looking for potential dehydration, especially if we see an increase in urine-specific gravity. An X-ray for bowel abnormalities. And we want a stool. I don't know what O&P is. I'm gonna assume that means output. I I I don't know. That word is not coming to my mind. If it comes up, I'll say it later. Um, but prevention, once again, meticulous hand washing and proper diaper disposal. What I was talking about before, you need to be very careful with this, okay? And contact isolation immediately until we know what's going on, okay? So no, when we suspect, you see diarrhea, fever, she's like, what do you do? Put them on contact isolation until you have more information, okay? For treatment of diarrhea, like we said, we talked about if it's dehydration and if they have it, depending on which level it is, what we do. IV fluids, maybe antibiotics if it's bacterial caused. Viral, obviously, you're not going to give antibiotics because antibiotics only treat bacterial infections. Fluid replacement, correction of electrolytes, and absorption agents or gut motility agents. Such as like, loperamide, like things to like stop. We don't want that. We don't want them to stop diarrheaing. We want them to, but naturally, because we don't want to stop it and it makes it worse. Okay. So we will not give them things like to stop them from going to the bathroom. The next thing is a pyloric stenosis. It's basically when the muscles in the pyloric part of the stomach start to enlarge and narrow. So we have this like really narrow opening between the stomach and the duodenum, and this prevents food from going to into the intestine. You typically see this in a baby of 1 to 2 months of age. They're gonna have projectile vomiting. Associate pyloric stenosis and projectile vomiting, and that when you palpate the stomach, you're going to feel an olive-shaped mass on the right upper quadrant. Okay, know that. And they could also have deep gastric peristaltic waves that could be visible. So, like their stomach can kind of rumble, you can kind of see something like movement right before they vomit. History and exam, it's gonna be how the vomiting is described. Instead of projectile vomiting, we're thinking pyloric stenosis. Our priority assessment is hydration and nutrition, right? This is not a respiratory complication. We're worried about them going into hypovolemic shock. Okay, so hydration status, nutrition is priority, right? And we can determine that through weight gain, right? Weight, that's the best way to determine hydration status. And then we look at CBCs. They could have a surgical procedure called a pyro pyloromyotomy. I'm going to say it like that, which removes a part of the stomach. Anything that ends in tomy, like ostomy, tomy, all of those pretty much mean like anything that ends in this kind of ending, basically like a removal, right? Because an ostomy bag is given when there's a removal of something. So just kind of think about that. When you see otomy, something's being removed. Okay. Now there's intussusception. Now, intussusception is basically when there's a section of the intestine into that distal bowel, which basically causes the bowel obstruction due to the fact that the bowels start to fold on themselves. It's almost like when you're folding your clothes or something, the bowels are doing that to each other. It's folding on top of each other. And it's most common in children under the age of 5. So these patients are gonna have sudden, really intense pain with inconsolable crying. They're gonna draw their knees up to their abdomen, and they're gonna have this abdominal mass that's shaped like a sausage, and they're gonna have passage of what we call jelly stools or current jelly of red jelly stools, bloody mucosal stools. I would know this specifically. I know she gave like I remember my exam like a selected that apply that had to do with intussusception, right? So the difference between this one and pyloric stenosis is that these are gonna have, instead of having that olive-shaped mass, right? These patients have a sausage-shaped. These patients have passage of red stools or current jelly, like bloody stools, and they draw their knees up to their abdomen. Now, all of these GI disorders are based on how they present. That's why it's so important to know these manifestations. So if we suspect intussusception and they have that, the first line of treatment is hydrostatic reduction if the child's stable. So basically, they're going to give like a barium or an isotonic saline or an air enema to cause that bowel to straighten out. Remember, it's like folded all over each other. Surgery if it doesn't work, which we call a laparoscopy. Nursing management, once again, shock. Remember, priority is still hydration status, so we're looking for signs of shock. We want to assess for sepsis, so fever, pallor, elevated WBCs, right? Shock, we know that there's going to be a decreased blood pressure, increased heart rate. Assess hydration status, right? CBC, hematocrit, mucus, membranes, sunken anterior fontanelle, poor waking. But the priority for these patients is pain relief, and that's because they're in intense pain. It's inconsolable. You're not going to be able to do anything with these patients until you relieve their pain, which is why the pain is a priority in this situation. Okay. The next thing is gastroesophageal reflux, okay? But it's not the same as GERD. This is basically a self-limiting, and it usually resolves by like 18 months of age when they're more able to sit upright. Um, it could be a long-term problem and go into GERD, but this is not GERD, okay? This is when they have vomiting or spitting up after meals. That's sometimes babies spit up. I'm thinking, oh, does my baby have gastroesophageal reflux? Well, if the baby has adequate weight gain, right? They're having their 6 wet diapers, right? We can reassure the parents not to worry, just keep feeding them upright, do burping techniques, and look at the wet diapers, right? That they should have a minimum of 6 and 24 hours. If they have adequate weight gain, they don't have this. But if they have weight loss, they don't want to eat or failure to thrive, they're irritable and discomforting, right? And they're having abdominal pain, and they have knees to chest when crying, things like that. We're thinking gastroesophageal reflux, right? So they are vomiting. The main symptom is that they're vomiting or spitting up after meals, but we see this in addition with weight loss and failure to drive and irritability. Remember, these patients have that knee to chest thing, but it's in intussusception. What makes that one different is we kind of already talked about, right? Intussusception, right? That they have that sausage-shaped abdomen, the current jelly stool. So you got to think about that. Like, what makes them different? Nursing assessment. Ask the parents. Priority is going to be hydration status and weight for these patients, but we also need to ask them about their techniques, right? Because that's going to tell us a lot about what's going on. To know about their hydration status and weight, that's our priority assessment. We do that by asking them things like, how much and how often are you feeding them? Ask them how are they burping them and how many wet diapers are they having in 24 hours. And we want to look at feeding patterns and nutritional intake. Nursing management, dietary alterations, make sure that the baby's always in an upright position for all feedings and after feedings for at least 30 minutes. That's our first intervention that we're going to do. No swings or infant seats because that's too much compression on the stomach. Tell the parents that. Tell the parents to elevate or hold the crib at 30 degrees and feed at a 45-degree angle. Small frequent feedings, frequent burping, thickening foods with iron fortified cereals is going to help, especially with maintaining their nutrition. And also making sure that they have concentrated high calorie formulas. Medications go with whatever your professor says, but what I had at the time is that there's proton pump inhibitors, which remember those help decrease the acidity, and so do histamine blockers like ranitidine or PPIs like omeprazole. Those help decrease gastric acid secretions, which could help with someone who has gastric reflux. And yeah. Now is this the last one? Yeah. The last GI disorder is Hirschsprung disease. I'm saying it like that. I don't think I'm saying it right. Basically, it could also be called congenital ganglionosis or megacolon. It's basically where there's this absence of the ganglion cells in the rectum, and it's all based on varying degrees in the colon and utero, but the rectum is very narrowed and the colon is very swollen. So we have a very colon swollen and a very narrow rectum. So, thinking, the rectum is narrow, the colon is swollen, there's a delayed passage or absence of meconium. That's the best way to tell if they have Hirschsprung's disease. They're also going to have chronic constipation, pellet-like or ribbon-like. Imagine, right? If their colon's really swollen and the rectum, to get into the rectum is very narrowing, that opening, right? They're not going to get much poop out. So they're going to have pellet-like ribbon stools. They're going to have delayed passage or absence of meconium. They're going to have abdominal pain, a lot of dissension. They could have vomiting and failure to thrive. They don't want to eat and they're not gaining weight. How do we diagnose this? Unlike the other ones where it's based on presentation of symptoms, we need to do a barium enia for this with an or ultrasound and a suction rectal biopsy. Surgical interventions is going to be necessary. So, preoperatively, we want to assess bowel function, bowel sounds, and measure abdominal girth or how big the stomach is distended, assess hydration status and monitor electrolytes, prepare parents for a colostomy for 3 months, right? Because they're going to have an ostomy bag. Post-operatively, vital signs, GI assessment, they're going to have an NG tube and NPO status, right? Until we could assess how well they're able to take things orally. Pain, hydration status, electrolytes, infections. Remember, we're making an ostomy bag now, so they're at risk for infection. They have an opening in their body. Assess dressing, making sure that we assess the stoma. Just like in adults, the stoma should be pink, shiny, moist. And look at the anal area, meticulous skincare, and colostomy care. I see a question.
Yeah, I have a question. So for the post-op care, what will you say is the priority? Like, what will you do first following the other?
I would say the priority, because we're still talking about a surgery, I would still say looking at, vital signs and specifically respiratory status, right? Because it still is a surgical intervention. But if that wasn't a choice, I would definitely pick, then like hydration status. Also, you have to think if it says something with a circulatory issue, that's also something we want to look at, right? But I would definitely say like doing like a good vital sign assessment, and especially for respirations would be your priority, especially post, we're talking about a surgical procedure. And then, like your ABCs, and then go into like hydration status, electrolytes, and kind of go from there. Because we know, right, their GI assessment for anybody who has a GI surgery, and what we're looking for is they could have, like hypoactive bowel sounds, right? Like, they could complain of like pain or things like that. But, if they have like sudden shortness of breath, right, they could have clotting from a surgery, right? That can turn into a pulmonary embolism. So we should always be thinking about respiratory and kind of go that from there.
Thank you.
Um, Other things is that you should know how to perform ostomy care, just in case she does ask. So, like, you should have warm, wet washcloths or paper towels. Make sure there's a clean pouch and clamp. Have skin barrier, powder, paste, um, scissors. I don't know what a pencil or a pen does. I don't know if that's an actual pencil or a pen or thing. So just look into that. I don't want to say I know what that is. And also make sure you have a way to measure the stoma. You need to make sure that when you take the pouch off, right, that you use adhesive and you be very careful with it, right, because you don't want to irritate or have friction on the skin. You want to reserve the stoma and surrounding, right? The stoma needs to be dried properly. Make sure that when you're looking at the stoma and you're measuring it, that you mark it properly. I'm guessing that's what the pencil or the pen is for, to mark the pouch, right? And then cut it the new size, and then you apply the new pouch, right? But remember, we're talking about an ostomy, so we're at risk for infection, okay? Any other questions?
And the stomas, they are not reused. The stoma bag, they are not reusable, right?
No. So after it fills and you throw it out, do not put it back on, because
Okay.
it's gonna be bacteria and stuff and poop in there, and you're not gonna. There's no way to really clean that, because then you're gonna put poop back onto a clean site, you know? So you can't reuse those, no. Um, but the bags, right? Like they are made that you have multiple of them, right? So you're gonna get lots of them, and you're gonna get lots of bags, but they don't need to be changed every day. They could be changed every like 2 days, depending on how much it gets filled. So you don't have to change it right away, but you can't reuse it. Um, okay. So all right, that's pretty much it for this chapter then.